All right, so the last video we have here over shock, this one is going to be over distributive shock, which has three shocks and entailed in that. You have the neurologic, anaphylactic, and septic shock by me, Nick Riesenberg. So physical examination, signs and symptoms, you have a change in mental status, increased heart rate, hypotension, tachypnea, decreased urine output, increased blood pressure, all pretty standard for the different types of shock, so really no difference there. But this image that I like here that I found, it shows a few of the other types of shock too, but we're really going to focus on the septic, neurogenic, and anaphylactic. So with septic, you're going to have increased heart rate, decreased blood pressure, and with the skin, early it's going to be flushed, later it will be cool and pale. So there's a difference between those shocks. And then the neurogenic, you'll have a heart rate that's decreased, blood pressure will be decreased, and you'll have dry, warm extremities. And for anaphylactic shock, you'll have an increased heart rate, a decreased blood pressure, and the skin will be swollen, itchy, flushed, because that's allergic reaction. So the three differences between those is your septic shock. It's a infection in the blood or in the body. So they may have prior symptoms that suggest an infection, like a fever. And for anaphylactic, commonly have exposure to an allergen or a coexisting or with coexisting respiratory symptoms such as wheezing or dyspnea. And neurological, they'll have some kind of spinal cord injury or something with their nervous system and spinal cord that has caused this issue. So with the imaging, chest x-ray to find the source of infection and to identify areas that may need drainage. CT scan is the test of choice to diagnose intra-abdominal causes of sepsis. So that's a big one for the septic shock. Abdominal ultrasonography used to assess fluid collections around the gallbladder or the head of the pancreas. Echocardiography for critically ill patients to evaluate cardiac function, fluid status, and response to hemodynamic intervention. Also exclude tamponade. So a lot of these different things are not only to help diagnose the actual thing, but take out any other options that it may be. So sometimes the best way to diagnose something is to make sure it's not something else. Lumbar puncture for unexplained neurologic findings or in patients with sepsis or altered level of consciousness without another apparent source of infection. So that's going to go for both the septic and the neurogenic one. So pharmacologic options, with a lot of them, the IV fluids, crystalloids, or colloids to reverse hypoperfusion and must be started as early as possible. That way you can help with either if they have that decreased blood pressure, increased or lack of fluid moving around or to flush out any infection and things. Vasopressors like dopamine, if fluid does not reverse the hypotension, you'll need that also increase their cardiac output and blood pressure. Vasoconstrictors or vasopressin to increase the mean arterial pressure and the SVR. Antimicrobial treatment, that's a new one for what we haven't seen for the other ones. The patients that are suspected to be septic, blood and urine culture should be collected prior, so they will not delay the treatment. Patients who receive prompt antimicrobial therapy are more likely to survive. So that's a big part with the septic one. The choice of antimicrobial agent should be guided by the patient history, the suspected site of infection, if they have any comorbid diseases, and pathogen suspectability patterns in the hospital and community. So it's to determine the actual cause of that sepsis. Disseminated intravascular coagulation, that's another one we haven't seen yet, or DIC, to prevent microvascular thrombosis and inflammation. So that would be a big one for the anaphylactic there, because there's a lot of inflammation already. That's an allergic response. Subcutaneous epinephrine, if anaphylaxis is suspected, administer immediately with repeated doses every 20 minutes as needed. And that's the big one for anaphylaxis. So hemodynamic monitoring, again, Swan's GAN catheterization to identify the different types of shock and monitor the hemodynamics. So I have each of these three distributed shocks here. So for septic, there's going to be an increased cardiac output, normal or decreased CVP, decreased pulmonary capillary wedge pressure and decreased SVR. Neurogenic is the same with the septic, other than instead of an increased cardiac output, they're going to have a decreased cardiac output. And then for anaphylactic, it's the same as the neurogenic. They're going to have a decreased cardiac output, normal or increased CVP, decreased pulmonary capillary wedge pressure, and a decreased SVR. So with the blood gases, I couldn't find a whole lot, but what I did find, especially for the septic patients, that they're going to have a mixed acidosis with different medications, different fluids, and maybe perhaps they might be hypoventilating, but it's going to be a mixed acidosis with all that different properties in the body or ones exiting the body as well. So mechanical ventilation, essentially what I found was protective lung strategy for the mechanically ventilated patients under this type of shock. So tidal volume of 6 mLs per kilogram for predicted body weight, upper limit of plateau pressure of 30. We don't want to go over that in general, but that's part of that protective lung strategy. Patients positioned between 30 and 45 degrees to limit the risk of aspiration. Spontaneous weaning trials, always. Prone positioning is recommended with adult patients with sepsis-induced ARDS. That's one reason that these lung protective strategy is used in a PF ratio less than 150. Avoid high-frequency auscultatory ventilation in adult patients with sepsis-induced ARDS. Assist controlled modes of ventilation are preferred because it can be tolerated with the reduced sedation requirements and may have less hemodynamic deterioration involved. So positive pressure ventilation, use a minimum level of PEEP to avoid a hemodynamic instability and overdistension of the lungs. Titrate PEEP. A patient that requires a higher level of PEEP should be monitored closely. So this also goes in terms with a lot of the other strategies when it comes to the positive pressure ventilation, but also with the protective lung strategy. You don't want to use too much PEEP. You don't want to over distend the lungs because if they have that ARDS-induced, that septic-induced ARDS, they've got a lack of compliance. So you don't want to over distend the lungs, but also because of the hemodynamic instability, you don't want to have a excessive amount of PEEP to impede on the great vessels and keep any venous return and decrease the cardiac output. So you want to titrate it as much as you can. You want to find the optimal level of PEEP for hemodynamic stability and oxygenation status. So that is the big key with this one. So in summary, signs and symptoms. Septic patients may have prior symptoms that suggest infection, a fever. Anaphylactic patients commonly have a recent exposure to some sort of allergen, whether that be, whatever they could be, is something environmental, food, anything like that. They could have a pre-existing exposure to that, and then also coexisting respiratory symptoms like wheezing or dyspnea. Especially the wheezing and the dyspnea comes along with that, but the wheezing because of that inflammation process, their bronchioles are constricting and starting to become inflamed, then they're going to wheeze, and that's a clear sign of that something's going on with that. And then the neurogenic shock will have some sort of spinal cord injury or something along with the spine that's causing that injury. Imaging, so CT scan is the test of choice to diagnose intra-abdominal causes of sepsis. And then the lumbar puncture, that was the big one that was different from anything else for unexplained neurological findings. Then I could go with the neurogenic and the sepsis as well. So pharmacologic options, a new one for this one was antimicrobial treatment, for sepsis. The disseminated intravascular coagulation to prevent microvascular thrombosis and inflammation. I apologize. And subcutaneous epinephrine if anaphylaxis is expected or suspected. So with the hemodynamics, with sepsis, you've got increased cardiac output, normal or increased CVP. You have a decreased pulmonary capillary wedge pressure and a decreased SVR. Neurogenic, you have a decreased cardiac output, increased CVP or normal, decreased pulmonary capillary wedge pressure, and a decreased SVR. And then with the anaphylactic, you also have a decreased cardiac output, normal or increased CVP, decreased pulmonary capillary wedge pressure, and a decreased systemic vascular resistance to the SVR. So with the mechanical ventilation, there's actually a lot more on this one than the other, a lot because of the sepsis-induced ARDS. Protective lung strategies, low 6 mLs per kilogram ideal body weight for that low tidal volume, low PEEP, You want to have optimum PEEP, that you're not going to over distend the lungs or cause hemodynamic instability. Assist control, so it was preferred for toleration with sedation, reduced sedation requirements, and may have less of a hemodynamic deterioration involved. And then the minimum level of PEEP to avoid the hemodynamic instability and the over distension of the lungs. Those were the big takeaways for the mechanical ventilation and the positive pressure ventilation. I hope you enjoyed my presentation in these videos. I enjoyed making them to a point. This was a tough assignment, but I did enjoy. I did come out feeling like I understood and learned a lot from it. So I hope that I was able to convey that. And thank you for your time, and goodbye.